Um, Hello, everybody. So this is a quite difficult but very important topic, weighing the benefits in the elderly of complications versus the benefits. So I would like to start with a clinical case. This is a 85-year-old female patient. The patient was referred for colonoscopy because she had an iron deficiency anemia and hemoglobin level was a little bit less than 10, and the IFOBT was positive. And he was directly referred for colonoscopy. She had some comorbidities, but not severe. Here you can see the sigmoid colon. It was a little bit difficult to get through that. It was a little bit stenotic and many large diverticular, but we managed to get through that. And then it was quite difficult to get to the cecum because of adhesions and loop formation. But at the end, we succeeded. But on the way back, we saw this in the sigmoid colon. So we had a large perforation, I think, because of the adhesions and because of the endoscope, the shaft of the endoscope, and then we had to send the patient to surgery. So this is one example where you ask yourself afterwards, and then the colonoscopy did not show any pathological finding, and there you ask yourself afterwards, was it really necessary to perform this colonoscopy in this 85-year-old lady? Let's come to some definitions. So I had a look how is elderly and very elderly patient defined, and the WHO says that the elderly patient is defined as 65 years and older, and the very elderly is defined as 80 years and older. But the problem with all those definitions is that, you know, there are different 65-year-old patients or people. So you have the 65-year-old marathon runner, and you have the 65-year-old patient with dementia and many comorbidities. And the same is with the 80-year-old. So 80 is the new 50. So I think there are some very fit 80-year-old patients and many patients also with severe comorbidities. So some background on this topic. We all know that with increasing age, we also have an increasing incidence of GI diseases, and also the incidence rates of cancer goes up after the age, beyond the age of 65. So colorectal cancer, 250 per 100,000 people were in this age group older than 65 compared to younger patients. Gastric cancer also 41 versus 3, and esophageal cancer 23 versus 2. And there's also an increasing incidence of pancreatic and biliary disease in elderly patients. And endoscopy is able to detect and also to treat most of those conditions. On the other hand side, elderly patients have a higher incidence of comorbid disease, and they are also more susceptible to endoscopic interventions, and also due to the decreased physiologic reserve and the associated comorbidities, complications may be more severe in those elderly patients compared to younger patients. And also, it's very important that ethical considerations play also a special role in those elderly, frail patients, and especially those with a poor prognosis. So endoscopists really need to pay special attention when considering or performing endoscopy and endoscopic interventions in elderly patients. Of course, we have to assess the potential preconditions of those elderly patients that can increase the risk of endoscopy, cardiopulmonary disease. We also heard a lot about medications like DOACs, Coumadin, so those blood thinners. You find much more patients in that age group on blood thinners than younger patients. And can the patient also be really consented for the endoscopic procedure? Does he have dementia? And does he have any implanted cardiac devices? All those are very important questions prior an endoscopic intervention. So the key question also is always, what is the diagnostic and therapeutic consequence of a given endoscopy? And I think this is something you have to ask yourself every time, and sometimes you might regret to have performed the endoscopy like I did with the 85-year-old lady. So there are very few established recommendations against interventions or endoscopy in elderly patients. So there are some recommendations regarding screening endoscopy, that you should not screen for cancer in patients with a life expectancy of less than 10 years, but it's very difficult to say how the life expectancy of that individual patient is. Avoid colorectal cancer screening in those patients, and another suggestion is to not screen patients after 75 years. It depends a little bit on the recommendations of the guidelines in your country. So let's start with sedation. Going to the literature, you find many different studies, and of course there are different sedation regimens. So there is a higher risk of hypotension, hypoxia, arrhythmias, and aspiration in the elderly. That's what you can find. But most studies used those benzodiazepines like midazolam as a sedative, and in those elderly patients you should use lower doses and slower infusion rates. But for example, in Germany, we mostly use propofol, which seems to be very safe in the elderly patient, but also the doses should be reduced. There are not many studies out using on elderly patients and use of propofol. Therefore, I contacted Angelika Behrens, who was the first author of the PROSAID study, and asked her if she has some information about complication in the elderly. And she said she it's not in the paper, but she made also an analysis whether increasing age was a risk factor. And she said age was not a risk factor for higher complication rate in this study, and almost 370,000 patients were included in this study. So it's more the comorbidities than the age that that are a risk factor for complications. And you also can consider unsedated endoscopy, which is usually better tolerated by the elderly patient, but you have to talk with the patient about that. Let's come to upper endoscopy. Upper endoscopy, going through the literature, is very safe, and there's no increased risk of complications, and it has a quite high diagnostic yield in patients with symptoms. So what do you find during upper endoscopy in the elderly patient? This was a retrospective multicenter study, more than 3,000 patients with an age range from 65 to 99 years. And they had a look at the symptoms the patients had. So alarm symptoms were there in 40% of patients, with anemia, dysphagia, weight loss, and bleeding and vomiting. And also epigastric pain without any alarm features was present 42% in this series. And having a look at the findings, so here you can see in this column with the columns with the different ages. So the youngest group, 65 to 69, the oldest group, older than 85 here. And you can see the endoscopic findings here, the very relevant findings increased with the increasing age. So in the youngest group, 65 to 70, you find very relevant findings in 6% compared to the older patients, older than 85 years, with 17%. And also the malignancy rate increased significantly here, 2% up to 7% in the oldest group. So the older the patient is, the more significant findings you will find during endoscopy. But again, you always have to ask yourself, does it have a therapeutic consequence? So when you have a very frail patient with 85, is it really necessary to find the gastric cancer? You always have to ask yourself this individual question. Let's come to colonoscopy. As with gastroscopy, there's a higher yield of colonoscopy in the patients with an age older than 65. And also, on the other hand, you have a lower completion rate of colonoscopy in the older patient, mostly due to a poor bowel preparation. So the completion rate in patients older than 80 years is 90% compared to the younger group, which was 99% in this study. You should not use sodium phosphate for bowel preparation in the elderly patient due to increased risk of hyperphosphatemia, hypernatremia, and hypokalemia. And PEG solutions are preferred in this age group. And there are also higher complication rates in the elderly patients during colonoscopy. And this fits quite well to the case I showed you. There are higher perforation rates during colonoscopy in patients older than 80 years. Having a look here at the incidence of perforations per 100,000. So it really goes up here up to 115 in this group of older than 80 years old. And also a very important risk factor is are the skills of the operator and also the comorbidities here. The question is to screen or not to screen in patients, in elderly patients. Should we perform the screening colonoscopy or not? And so this is a study I found on the burden of the screening of screening colonoscopy. So 212 patients older than 70 years who had a positive FOBT. And they had a look at the benefits and the burdens of the screening. And a little bit more than 50% of those patients received colonoscopy. They found 6 cancers and 35 significant adenomas. And 10% of those experienced complications from colonoscopy and cancer treatment, the subsequent cancer treatment. And 46% of those without colonoscopy died within 5 years from other causes. 4 patients without colonoscopy died from colorectal cancer in this group. So, and then they had a look at the screening efficacy and the benefits and burdens of in these patients. So this is the group with the best life expectancy, so where with not many comorbidities, and where the investigator said this is the group with the best life expectancy, this is average and the worst life expectancy. And here you can see the burden and the benefit, and you can see in this group with the best and average life expectancy, the benefit was here 15% and here 20%, but still the burden here was 70% and 65%. And of course, in patients with a life expectancy which is not very high, then you definitely should not perform screening in those patients. Let's come to ERCP. ERCP is a very high-yield procedure in patients, and there's no difference regarding cannulation success compared to younger patients, according to the literature I found. On the other hand, you see more patients with diverticular and the papilla in the diverticulum. But according to the literature, there's no difference regarding the cannulation success. And it seems to be very safe in the elderly and very elderly patient. There are several publications out there, and there are no higher complication rates. What are the common findings during ERCP? Bile duct stones in 42%, malignant bile duct obstruction in 20%, benign bile duct obstruction in 8%, and papillary adenomas. And you can treat all of those diseases endoscopically. What about here the complications and deaths in ERCP in very old patients older than 90 years old compared to a matched control group with the age of 65? You can see that there is no real difference regarding the complications, and also the death rate was not significant. There was one patient who died from ERCP, but it was not significant comparing the younger patients with the older patients in this series. Interestingly, the post-ERCP pancreatitis rate was significantly lower in the old patients compared to the young patients. What about PEC tube placement? Complications that are associated, we heard about that, are diarrhea, constipation, infections, aspiration, deaths also in 1% to 2%, and also bleeding, of course, and that's really a high risk procedure with many complications in frail patients, and that's something you should always think about whether you should put in a PEC tube or not. I had a look whether there are real recommendations against some interventions, and I found choosing wisely, and they again make recommendations against colorectal cancer screening in very old patients with a limited life expectancy, and also that you should not insert percutaneous feeding tubes in patients with advanced dementia. You should offer oral assisted feeding. This is those are clear recommendations against procedures. So I would like to conclude. Endoscopy in the elderly patient is usually safe. Colonoscopy is associated with a higher perforation risk. You should keep that in mind. Less complete colonoscopies are usually due to, in elderly patients, due to poor bowel preparation. And for bowel prep, you should use PEC solutions in those old patients. Sedation with propofol in the elderly patient is safe. You should not perform colorectal cancer screening in patients older than 75 years old or with a decreased life expectancy. No PEC placement in patients with dementia, and especially in the elderly patient, less is sometimes more. Thank you very much.
Thank you very much for this talk on a very important issue in a population which is growing older and older. And we as surgeons are each day more or less in a situation to discuss whether to operate or not. And that's why you are in the same position concerning endoscopy in diagnostic and in interventions. There's a question.
Yeah, thanks very much. Great talk. I wanted to sort of focus down on the ERCP data, which, as you say, shows that ERCP in the elderly is very safe, and I think that is an important point to make, because there has, of course, historically been a view that in the elderly patient with biliary obstruction, you know, you go in, you don't want to do much, you don't try and take the stones out, you just put a stent in, and they're much too sick to have anything else done, and then you leave them. When, of course, data way back from the 1990s now, Jack Bergman and others showed that if you follow a policy in the very elderly of putting a stent in and leaving them, at least 50% of those patients will come back with biliary-associated morbidity and even an associated mortality with that approach. And I think this data shows that whatever the patient's age, if they present with biliary obstruction due to stones, we should really be pushing to clear the stones in those patients.
Totally agree, yeah.
Next question.
It's not a question.
It's a comment.
It's a comment. The first patient you presented was a diverticular disease with adhesions in the sigmoid, and I can really recommend on these patients to use the pediatric instruments, because
we use the pediatric instrument.
I believe that, but I know many hospitals that don't use that at all, and I think that is an important recommendation.
Okay. Next question.
Thank you for your excellent presentation. I had a question because of in the patients with 90-year-old patients that want to have colorectal screening colonoscopies. what would you advise them? They come to you and tell you, please, I don't want to die of colorectal cancer, do an endoscopy on me?
This is this is an important question. I had exactly that case on Monday. So I have my outpatient clinic, and there was a 93-year-old patient who was brought in with a wheelchair and asked for a screening gastroscopy and colonoscopy because he had once bright rectal blood per stool. And I persuaded him not to do that because we will have a higher complication rate in that patient. If we find a cancer, it won't have any consequence. So I persuaded him. He insisted, and I said, okay, I will do an unsedated colonoscopy, unsedated sigmoidoscopy, and to prove that he has diverticular and hemorrhoids, and that's all. And he agreed. And he had diverticular and hemorrhoids.
But it's an ethical issue, isn't it? Yeah. There was also a New England article on that, and they say you have to stay flexible. I'm not sure how flexible you have to stay.
If he doesn't do the colonoscopy, he will move to the next one. And he
Yeah,
will
that's the
get
problem.
one, at least in Germany. And I think an important message of this talk is it's not about what the patient has age in his passport. It's all about biological age.
Yeah,
And
exactly.
we are living in an era of individual tailored medicine. And that's why we should take care of the patient in front of us, and we have to discuss about benefits and disadvantages and so forth.
I mean, but yes, I mean, in a wheelchair, that's the message there, isn't it? Is that they're not going to be able to cope with the bowel preparation or with the procedure or with the complications, certainly. We use a lot of CT colonography in the UK, the older age group, which is a fantastic test in good hands. And however, we now have the problem where we have the 8-year-olds who's got a 8mm polyp in the right colon that is referred to us, and they're again very difficult to dissuade. But I think you always have to ask the question, and you sort of said this, what if? So fine, yeah, mostly it's going to go fine, and you can do a cold snare on a right-sided 8mm polyp, but that really is not going to make any difference to that patient in the long term. And what if they have a significant complication? So I would disagree and say, I would say to a patient, I'm not going to offer you a colonoscopy. And if they choose to go somewhere else, someone else will do it, then that's their responsibility. But I think we can say to patients no.
Yeah, absolutely. We should.
Okay, any more questions? Please.
Well, in our region, people are 92, they go skiing, they are mountain hikers, they are biologically 70, and they come in. If they come with blood, it's not a screening colonoscopy. It's a diagnostic colonoscopy for a bleeding. So I would really separate this. I would sure endoscope a patient with fresh blood in the stool. I would offer him a colonoscopy, but that's not a screening colonoscopy. That would mean he would be completely symptom-free and come in and ask for a screening colonoscopy.
But I bet you would not have offered this patient.
Maybe
So I bet not.
but well, if he would be bleeding, yes, why not?
But
that's not an offer. That's not really.
But once bright red blood on the paper. Yeah.